There we go. Welcome to anybody who will see this. My name is Brandon Davis. I'm the founder and executive curator of Culture Champion Creative, and I'm here with Dr. Devin L. Patterson. If you would like to introduce yourself.
Well, actually, I think you just did. My name is Dr. Devin Patterson. I am a tenured associate professor and counselor at the Community College of Allegheny County, also known as CCAC. I also am a licensed professional counselor. I've been in practice since 2010, so I've been in private practice for 15 years. So, again, very passionate about the mental health profession.
So y'all didn't say all that. I just said the name. That's an introduction. And the reason why we're having this conversation today is to actively participate in Suicide Prevention Awareness Month. And we're going to talk about Johns Hopkins Rapid Method, which is just a practical way to show up and support your loved ones. I completed the specialization, so I'm repping Johns Hopkins today.
Okay, that's a nice little sweatshirt hoodie thing they got
there. And it's a Black brand, so we're supporting Black business. Brother, if I'm not mistaken, he's in Baltimore where Johns Hopkins is, and his brand is called Gains Sports Gear. So that's Gains with the Z. So, you're in the gym getting gains. So it's Gains Sports Gear collection. So Black owned, Black product. We're supporting Black business. And today we're having a conversation around Suicide Prevention Awareness Month. And we're going to walk through the rapid method of psychological first aid according to Johns Hopkins. So, and I want to frame the conversation because I want to make sure that everybody can kind of be on the same thinking plane when we're talking about these things. Psychological first aid is something that everybody can do. It's something that everybody can do, and everybody can use these tools to show up for their loved ones and show up for the people that they care about, and even recognize the things in yourself. And it's a method that is used in response to an event, response to life occurrences. So we're talking about stresses, we're talking about bills, we're talking about social events, we're talking about watching things like ICE walk down the street. On social media, we're watching families being taken and torn apart. So extreme life stressors like job loss. Of course, if somebody is contemplating suicide, these things that we see every day and we kind of just deal with it, they have an effect. And what we're talking about today is peer-to-peer, person-to-person, family member to family member, how you can show up. And I also want to add a layer to keep in mind that our culture and our community is oftentimes in survival mode. So we already are in a certain state of reacting to the world. So I want to just walk through these and get your reaction and your professional advice of the rapid method. And the rapid method starts with rapport, which is rapport and reflective listening. So knowing the person, seeing what they have to say about a situation. So it's listening to them and not really interjecting your own opinion, but listening. So is there anything that you can add to that, or is there some tools that you could give us so that we know that we're listening and we're listening correctly? And could you, it's probably a long question, but could you really define the rapport? Like, just because we're co-workers at the water cooler, that doesn't mean, you know what I'm saying?
No, I mean, and really, they actually touched on the single most, and research actually shows this, the single most indicating factor, whether any kind of therapy is going to be successful, is the relationship between the clinician and the client. In other words, the relationship is going to be the number one determining factor in terms of if it goes north, south, east, or west, left, or right. That's going to be it. If there is no relationship and no rapport, the clinical relationship is dead in the water. The helping relationship is dead in the water, because the person sitting across from you must have some degree of trust in that. And this is very important. So there's two things that you have to take into consideration. In the relationship that you're kind of in, people can either be coming from one or two perspectives. And the question is, I teach my clients this: is this person trying to help me or hurt me? Very simple questions. Help me or hurt me? If I believe that you're trying to hurt me, guess what? I'm going to be less likely to listen to anything that you have to say. It's the reason why, and I know I'm sidestepping this a little bit, it's the reason why a lot of times most of my clients are African Americans, right? That's because they may have sat across from somebody who doesn't look like them. And so for them, the element of trust is not there. So it's harder for them to open up because they may feel, and they may either feel this, or they may be getting this, from the therapist himself, that you're judging me, you're critiquing me, you're pathologizing me, and pathologizing means you're diagnosing me. All I said is hello, and all of a sudden you saying, oh, this dude's crazy. So the rapport is most important. Listen, me and you've known each other, I guess, I don't know, about 7-10 years, I don't know, something like that, right? So how long has it been, bruh?
Since 16, so we're coming up on 9.
Okay, so I was close. Yeah, 7 to 10 years. So there are things that, guess what, that I know that I can say to you because of the relationship. There's other people that I'm going to have a lot softer or a more gentler approach, and more of a timid approach because I don't really know them. But at least you know me enough that, okay, if Devin is saying this to me, I at least believe on the surface level that I'm trying to help you. So that's why that part is so important. If that's not there, if the person doesn't believe that you have their best interests at heart, you're trying to hurt them versus help them, dead in the water. And that's why that's vitally important. Also, I'll add this. When you are having this conversation with this person, one of the most important things when you talk about the listening part is, the one thing you cannot do is begin injecting your thoughts and feelings into the situation. You want to listen. You don't want to preach. You don't want to give advice. You want to just listen.
So what you're saying is, if it's, this job isn't working for me and it's depressing, and the response should not be, well, maybe you should quit.
Right. It definitely cannot be. It definitely should not be that. It is you simply validating what they are saying. Because if you go into the mode of trying to prescribe and tell them what they should do, in some way, shape, or form, this may have been something that they heard before. This may have been coming from a relative or a co-worker, somebody who's trying to critique them and tell them how much they're messing up. You doing that may in fact be validating some information that they've already heard that they themselves have rejected. So it's best to do. There's a thing in psychology that you learn. One of the fathers of psychology, his name is Carl Rogers, and one of the things that he said was, in therapy, what you have to do is you allow the client to lead the dance. In other words, you let them, the direction that they want to go in, that's the direction that you want to go in. You don't try to lead them. You follow them and you walk with them. So wherever it is that they want to go, that's where you need to go as well. And if it just means you sitting there allowing them to vent, to listen, and that's fine. That is perfectly fine. Because when you're talking to somebody, you can be either doing one or two things. You got to be careful on which one it is. And depending on who the person is, I'll ask this question: do you want me to listen, or do you want me to give you some advice or suggestions? Sometimes people just want to just vent, and that's okay. If they want to vent, the last thing I need you doing is giving me advice and telling me what I should and should not be doing, because now you're critiquing me. I don't want to hear that. Other times it may call for that, but I say, Brandon, man, you want to know what? This is what I'm dealing with. Can you give me some suggestions or ideas on how to handle this? I'm not asking for you, I'm asking for you to listen, but I'm also asking to get your sound advice or what you think I should do next.
I love that, because number one, I'm not a doctor. For anybody who sees this, I am not a doctor, but I have worked in mental health for 12 years. My degree is in psychology. And my friends, knowing the individuals that I work with, I feel like kind of inspired them to maybe ask me whatever questions, or, casually, even when we're just talking, I would ask them that question. I'm like, okay, do you want me to listen or do you want it?
You got it.
Looking for advice, because working, having that mind and regular me is different. So I feel like for anybody that's listening, when you are in the R phase, which is rapport and reflective listening, when you're in that phase, make sure that you know that you're performing a task. This is not something about a personal view. If your task is to show up for your loved one, show up with them in that manner. And I like that, because that also takes us to the second letter in the acronym, which is assessment, which is the ability to tell who is in distress, not diagnose, but to tell if they're in distress. Now, I want to be clear, just because I'm a stickler. Again, my degree is in psychology. I am not a doctor, but I'm a stickler about people diagnosis. And I feel like in our culture, we learn the word and it's just that. We throw it on everybody. People learn the word narcissist. Now everybody's a narcissist.
Oh my God, everybody's a narcissist.
You know what I'm saying? So could you talk about that as a doctor, as a professional? Could you tell us about just the assessment, not to diagnose, but can you just elaborate and give us your thoughts and opinions on that?
Right. So assessments are relatively easy, and I'll give an example, because diagnosing is one thing, but assessment is very easy. So an assessment is going to be primarily based upon external factors. So I can assess right now, Brandon has on glasses. Brandon has on a John Hopkins sweatshirt. Now, and again, the way that could be an assessment to go into a diagnosis, let's say if it was 110 degrees outside. Now, and you got on that sweatshirt. I'm simply reporting it's 110, Brandon got on the sweatshirt. Now, that may seem, and I can say, he's not appropriately dressed for the weather. So an assessment is simply describing a behavior. An assessment is simply saying, reporting what you see. Okay, I observed Brandon pacing. I observed Brandon, he was irritable. All those are external things that I can observe. That's the assessment part. Relatively easy. The diagnosis is talking more on what's going on and is the part that you can't see, right? And again, that's more specific. And like you said, it's pathologizing, it's diagnosing. That's more specific. It takes a little bit more skills to do that. But the assessment part, you can do that. A person, and I'm pretty sure in the thing that you got, it talked about assessing for suicidality. You know what I mean? So you're listening for if a person is if they've changed in their behavior, all of a sudden they're sleeping a whole lot more, they don't have a desire to go to work, they're talking negatively about their, and I call it the depressive triad, right? One of the things that you can assess, and this is a tool that I teach people, the depressive triad is somebody having a negative thought about the past, present, and future. Depressive triad. So it's all three. So I have a negative thought about my past. Man, you know, I was physically and sexually abused as a child, this, that, and the third. I was called fat, ugly, and stupid. Nobody loves me. Currently, right now, you know, I can't stand a healthy relationship. Boom. I don't see there being any hope, because based upon my past and my present, the depressive triad comes. Now I'm thinking of my future in a distraught manner. Now I'm thinking of my future that it's going to be the same of what it is now. And so when people get into the suicidal ideology, they're thinking of, in other words, for them, there's no hope or no release from the pain in the future. So why bother? Based upon my present and my past, I'm thinking the future is also dead in the water, the depressive triad.
So I like that, and I want to expand on the suicidal ideology. It's not a regular form of thinking. It's an altered state. I want to expand. So when somebody is going through this, and you can tell, which is what the assessment part is all about, you can tell by putting the external factors together, you can identify that, okay, something is wrong. So it's not a situation where you can put your bias in there and be like, hey, you know, they're rooting for the Patriots. What is wrong with them? So you can't put your bias into it. You have to look at the factors and then put that all together. That's how you assess.
Excellent point, because like I said, you know, the external things. And that's why I said assessments can be easy, because it's pretty much you're following a checklist. You know what I mean? Like and it's going to tell you what to look for and how to look. It's very easy. But like you said, when you start incorporating your interpretation or misinterpretation, depending on how it falls, your interpretation or misinterpretation of it, now there's room for error. But if you follow the assessment guidelines, it's telling you the checkpoints, like, okay, this here, report that, this is what it is. And once that information is logged in, then it goes to the next step, which is potentially or possibly a diagnosis. And like I said, the suicidal ideation, those are things that it is a temporary, fleeting mindset that a lot of times goes. Now again, if somebody is continuing to have those thoughts, now that's something entirely different. And even with that, I'll say this: most of the times you'll have people who will believe and think that, and it's not to dismiss it, but when we're still able to assess and determine that a person is having suicidal ideations, those are still typical calls for help. They still can be tossed a lifeline. There is still hope and the possibility that things can be turned around. And I'm pretty sure that your training taught you this. It's when you're not able to read the person per se, that's when the concern comes in. Because when a person completes suicide, when they actually do the act, the research says this, because we'll believe that, well, if I had known this person was going to do this, if I had known, I could have prevented it from happening. 70% of all suicides that are committed, the decision is made within 1 hour. You don't have time. Like, you know what I'm saying? So if I decide to kill myself today, I'm gonna make that decision. I'm gonna do that in less than 1 hour, which means you and nobody else, more than likely, is not going to have time to prevent it from happening. Then a lot of times, if the person has made up his or her mind, they call it's this sense of calm. We tend to look for these irrational behavior, and I'm going to jump out the bridge and I don't want to live. And again, that's not to say we need to dismiss that. Right. But when a person has made up their mind in a decision, there's going to be little to no clues. It's just going to happen. And I'm saying that to say they made up their mind, that they are able to appear to be as normal and as happy as possible. Talk to anybody who's had a relative or a close one who's committed suicide, and more than likely they're going to tell you he or she seemed fine. They ain't going to say, it ain't going to be that person, I don't want to live anymore, I want to kill my... And again, I'm not knocking and saying that we shouldn't pay those things any attention. I'm not saying that. What I'm saying is that almost 90% of people who complete suicide, they don't fire a warning shot. It just happens. It does.
I actually like that you said that, because right now this conversation is taking place during Suicide Prevention Awareness Month. So a lot of people, including myself, are sharing tools, are sharing as much information as we can about helping your loved ones. And a lot of those are warning signs. So I do want to add some nuance to the whole conversation. Is these are things that are supposed to help, and they're not supposed to necessarily fix. I mean, like you said, if somebody is feeling this way, the majority of the decision is going to be made within an hour. You can't assign any grief or I should have done something. I mean, you can grieve. What I'm saying is you can't assign the Superman's complex to yourself in this case, because this is something that's beyond you. This is a thought process or a feeling within the other person. So it's nothing that you can run in and just say. So that, and I think that goes back to the framing of the conversation. Times like this, I feel like with so much going on in the world, we have to, this is going to sound so hallmarky, but we got to be kind to each other, because, the age-old adage is you don't know what people are going through.
It's true.
So if you don't know what people are going through, I'm sure, and I would hope most people don't want to be an added agent to their demise. I would hope and pray that. But that leaves us to the next letter in the acronym, which is P for prioritization. So knowing who you can help and who you're able to touch. And I'll add that, number one, you don't have a rapport with everybody. That doesn't necessarily mean you are the one just because you knew somebody. It's about the relationship. We go back to the first letter in the acronym. It's about rapport and reflective listening. You have to kind of, I would say, weigh out and assess who you can and can't help. Again, I worked in mental health for 12 years, and I think one of the most prolific things that somebody could say is, I'm not the best for this person, for this consumer. I think they should transfer to whoever. So could you expand on that and tell us your thoughts?
It is, and listen, people just, and again, especially in the clinical setting, people just organically, to your point, are able to and connect with people in different ways. That just happened in a lot of different ways. Because we're creatures, we want to feel comfortable and safe. We are always looking for similarities. Think about it. When you walk into a room, you're trying to find somebody that's similar to you. I don't care if you're walking and looking for another African American, if you're walking and looking for another male, somebody else in your age bracket. in your profession, you're looking for somebody, you walk into this room, this crowded room, you're looking for somebody who is similar to you. And once you see somebody like you, there's a bond and a connection, and there's a safety that's felt with that person. So understanding that you are not able to touch every person is, a lot of times, regrettably, it's one of the things that a lot of people in the profession, including myself, is a hard pill for us to swallow, because you mentioned the Superman complex. Right. We feel that we have the ability to connect and save everybody. It is vitally important that if you make the decision, if you have a person, a family member who is depressed and going through whatever, the one thing you have to, if you decide you want to open up that Pandora's box and so-called help them, the one thing you cannot do is abandon them. You have to be willing and able to commit to that process and see it through to the very end. If not, you're making them more vulnerable, more susceptible if you try to and get yourself involved, but then you decide this is too much, I can't handle it. So you really need to ask yourself, am I willing and ready to devote the time and energy and effort into helping this person? And then also, again, realizing that you're not going to be able to help and save everybody. But that doesn't mean you abandon them. What it does mean is that you can give recommendations, you can give suggestions in terms of, hey, have you considered or thought about reaching out to this organization, to this person for therapy or whatever the case may be? Because it may be something that's beyond your skill level, your wheelhouse, your ability to commit. And if that's the case, you got to be okay with saying, I'm going to give you a warm handoff. I'm going to send you somewhere where I think somebody is more able and suitable to help you. Because another thing that happens when somebody is in a distressing mode, they're anxious, whatever the case may be, they're suicidal, sometimes they call it psychological dumping. And so if I dump something on you and you don't have the capacity to handle that, now I've now given this to you, I've now put this in Brandon's lap. And if it's too much for you to handle, me telling you that has done more harm than it to you than it do. I'm trying to get help and I'm dumping it on you, and you don't have the bandwidth or the ability to help that. And if that's the case, you need to be able to know that, hey, this is beyond my pay grade, this is beyond my ability, send them out somewhere else.
That actually goes into the last two letters in the acronym, which is I for intervention and then D for disposition. So for intervention, it's knowing what you can do, what you have the capacity to do. Check on your loved ones, check on these people. Don't just have one conversation and just, okay, they're fine, walk away.
Yep.
Go check on them and then see what you can do. Can I decrease your stress by going to dinner? Can I help you out a little bit to do your dishes? I know in our culture, being African-American culture, if there's a funeral, we bring food to the house. We try to
right.
To decrease the stress. And then D, disposition, that's following up and then seeing what they need. If you go and you have these conversations and it's not working and it's persisting, do they need professional help? And that's where you go from PFA, psychological first aid, to professional health, is sitting down with a doctor like yourself. So
I'm gonna tell you, bring up something vitally important, like that follow-up, right, that you just talked about, and I'll use the example that you gave, so when there's a funeral in the African-American community, and as well as other communities as well, that's the time, guess what? The house is filled with people. There's all these people there, everybody's there, everybody's loving on you and checking on you, but eventually people are going to stop calling, they're going to stop coming past. And so that's the time. Now, again, not saying that you don't need it then, but truthfully, when something tragic happens, because there's so much planning involved and, the shock and the surprise of it, people are still kind of like, they're kind of like in like they're on just automatic and co-pilot. They're not even, because so much is happening, they're not even able to process really what's happening. Once time has passed and the impact and the settling in of what just happened settles in, that's when they really need those follow-up. That's when they need those calls. Because there's 5 stages of grief. You got the denial, so somebody kills themselves, so there's the denial that it happened. Then there's the anger. There's I can't believe this person did that. Or I could have stopped this from happening. You're angry at something or somebody. Then there's the bargaining, is the shoulda, woulda, coulda. if I had done this, if I should have done that, then maybe it wouldn't have happened. Then the stage when people are needed is during the D stage of the 5 stages of grief, which is called the depression. So you got denial, you got anger, you got bargaining. 4th stage is called depression. That's where a lot of people, the phone stops ringing. Now, the final stage of that is called acceptance, where they embrace and they've accepted the fact that their loved one is gone, tragedies happen. But a lot of people get stuck in that depression stage because the phone ain't ringing. All the people that was calling and checking on you are no longer doing that. That's when they're processing what has just happened.
Right. So only with a couple of minutes left, I want to be very clear. This conversation was to provide tools that everybody can do, that any and everybody can do to show up for their loved ones. Now, if they need more help, more resources, seek a professional. Go see a doctor, go see somebody who is licensed and trained to perform the kind of psychological and mental work that individual or your loved one needs. And if anybody is having thoughts of suicidal ideation, having thoughts of self-harm, 988 is the national crisis hotline number. 988. Please dial that. And just know that it's okay to not be okay. I mean, we're just not.
It is.
We're just
as another sidebar note. Now, especially in the Black community, which is sad. So suicide has doubled in the Black community in the past 20 years. Doubled. That's scary. It's doubled in the Black community, and it is the 3rd leading cause of death with teenagers between the age of 10 and 24. 3rd leading cause of death, which is crazy. And our stats have never been that high. It's the 3rd leading cause of death, African Americans 10 to 24, and the suicide rate in the Black community has doubled in the past 20 years. So a lot more people are dealing with and struggling with this. And, in our community, there's always we don't ask for help. That's the other people's thing. But we have to get out of that mindset so that we're not just are physically healthy, but emotionally healthy as well.
And overall, we just got to get back to being kind. And I don't mean a kumbaya where we got to.
True.
We got to get back to being able to uplift each other in everything, economics and just social aspects. I think we've caught on to the bug of tearing each other down, and now we're addicted to going after a gotcha. Everybody's trying to get the next man. We got that.
Yes.
So only but a minute left. Is there anything you want to add just to put some more icing on this cake here?
The last and final thing, especially within our community, that it is okay, as they say, to not be okay. And the one thing that I often will say to people is routinely, we're always encouraged all throughout our lives, is to go get an annual physical checkup. That same thing needs to apply for our mental health. I would strongly recommend that if you can go get a physical every year annually, that you check in with a mental health professional, not your Aunt Bunny, your cousin Pookie. Right. Check in with a mental health professional to check and see how you're doing mentally. I strongly encourage that. It's something that I kind of contemplated on and been thinking about for the past couple of years. Like, we do physical things every year, but guess what? Emotionally, we should be doing the same thing.